Good day, dear friends. Today I will be talking about the very basics of kidney transplantation. Now, this comes as a theoretical short note for NEET exams, and you can understand all these uh, final exams. So, until and unless we are doing MCH or DNB exit exams, we don't go very thorough on kidney transplantation basics. So we're talking about the basics. Okay, so I will be creating a more advanced course, but for urologists, for people who are doing urologic training and not nephrology. It's a very important part of nephrology syllabus, but for urology training, it is not very important as a practical case scenario. For theoretical questions, it does come. Okay, so let me share my screen and share my presentation. Okay, so here am I. So this is the basics about renal transplantation as a treatment of choice in end-stage renal disease, and it offers better quality of life, better long-term survival, vis-a-vis hemodialysis. Because normally, what most of the patients are on hemodialysis, ESRD patients, grade 4, grade 5. I mean, advanced stage of chronic kidney disease, but less than 15 ml. Less than 15 the value of the GFR level. Obviously the treatment of choice is actually, that is the ESRD. Treatment of choice is the donor, the kidney transplant surgery. Now, it was the first done in 1954, the perfect match from one twin to the other. So this is just a historical aspect. The barriers is basically the procedure, because it needs a more advanced team approach, a nephrology team and a urology team alike, with a surgeon dedicated on nephrological surgical aspects. Okay, all this the vein and the artery anastomosis and the ureteric anastomosis, the bladder, this all requires technical expertise. So a person who is doing regular transplant surgeries, they're forming the team. So as you can see, most of the patients are on dialysis. So the patients are lined up on the transplant registry. Not all centers are doing transplants, maybe due to some legal attachments to this form of surgery. So what we do is that, so we need to maintain a long register. So the patients on dialysis, they're on the register, and depending upon the number of the listing, they are taken up for surgery, depending upon the donor availability. That's the big issue today, donor availability. Now, the surgery, the grafted kidney, this is normal native kidney. Normally, we don't actually excise the native kidney until and unless the kidney is very large enough, as in case of ADPKD, and it may cause problem in grafting the kidney, the foreign kidney. So the kidney is placed in the right iliac fossa, and the arteries are obviously end on end or end to side. They are basically anastomosed to the iliac vessels, and as you can see, the ureter is anastomosed to the bladder and via digestate. So this is a surgical procedure to, if you want to define kidney transplantation surgery. So it's a surgical procedure to remove a healthy functioning kidney from a donor and implant in recipient with a non-functioning kidney. So these are the, as you can see, these are the indication. We talked about ESRD, malignancy, hypertension, diabetes. Diabetes nephropathy is one of the leading causes of patients requiring kidney transplantation nowadays. And there are other as well. The contraindications is that the cardiac and the pulmonary insufficient, the reserve must be well for the recipient. Also the hepatic disease and the concurrent tobacco use and morbid obesity, and also active HIV infection. Right. So early transplant, there's a more benefit. So less the time on the registry and and early the transplant while on dialysis. It has improved graft survival if transplant in the first 6 months. Can you understand on dialysis? Improved patient survival if it is less than 1 year. So earlier to transplant, the better long-term function. Here is another crux. There's something called the preemptive transplant, which is transplantation has been done before the dialysis, hemodialysis or peritoneal dialysis has actually been started. So it has been shown, it's very common in the Western countries where we don't have that long list we have in India about this transplant registry. Is that decreased rejection rate by 25%? And understand that this, the cost of the immunosuppressive treatment has been radically has been decreased by this preemptive transplant. So improve graft survival long term and improve patient survival. All this because of delayed graft dysfunction, less delayed graft function, better graft function in the long term, and obviously decrease overall hospitalization in the post-operative setting. There are different types of donors. We have a living donors, the most common. Okay, living donors are, we have to evaluate the patient on physical and psychological grounds, because these patients are not patients. These are normal individuals like you and me. Okay, they are doing a great service to the nation, great service to the family of the recipient by donating his kidney or her kidney. So that's very important. First is the patient must be motivated enough, and the surgery must have least amount of scarring and least amount of complication for that. That's why we're using more of laparoscopic donors nowadays. Okay, and assure the patient there will be no long-term harm to the donor. And in some cases, living donor may develop a hydrocephalus due to lymphatic leaks. Okay, this is time sensitive. Go with conservative. Most of them settle down, and they're mostly laparoscopic because that's the less scarring and faster recovery. Now, about the disease donors, there are two types of disease donors. One is the brain dead donors or the beating heart donors. And while one is a donation after cardiac death, when obviously they have been written down by the patient and the relatives that they withdraw the life support system because they are basically brain dead. And because they're on ventilator, they're basically slim chances of survival. Now, a deceased donor is a deceased donor transfer, the transfer of the donated components who has died. That's it. And there are several criteria you can understand. There's several criteria. I'm not going into details today. It's called a standard criteria donor, extended criteria donor kit. It all depends upon the several parameters after cardiac deaths donors and high social risk donors. Now, compatibility, this is very important. You have to be ABO compatible. The blood group must be compatible. And the recipient should share as many of HLA antigens and minor antigens as possible. Immunosuppressant drugs are given to prevent the antibody, because whatever you can understand now, whenever you graft a kidney from another person, it's basically a foreign thing, and our immune system will lodge an immune response. That's normal. So if the immune system is able to lodge this, force this immune response against this foreign graft, then the graft will obviously fail and go for graft dysfunction. Then the whole purpose of the transplantation is lost. So we have to give him immunosuppressive treatment to suppress his immunity. This can cause secondary infection, but the importance is to keep the graft function intact. Because it's a foreign object, there will be some mismatch in the compatibility index. So, and perform the antibody test on the potential recipient. So preparing for kidney transplant, obviously go for blood group matching, tissue type matching, and the cross matching. So three important matching you have to do in three areas. Okay, the blood group is very important. We know what is a blood group. Type A goes to type O and B. This is a normal blood group donation. We all know. This also is pertinent in this kidney transplant or any transplant procedures. HLA typing is known as tissue typing, and HLA stands for human leukocyte antigen. These are proteins in the cells of the body, and there are 100 different antigens. Of the 6, we inherit 3 from each parent. So that is the chance of a perfect 6 antigen match between 2 unrelated person is the amount 1 in 1 lakh. That's, you can see, the 1 in 1 lakh. There's no way to predict who will experience a rejection episode. Living donors with a 6 antigen match also do allow the opportunity for decreased immunosuppression. Again, a 6 antigen match is a rarity. Okay, that's very important. The complication are rejection, infection, sepsis, post-transplant lymphoproliferative disorders, electrolyte imbalance, as with any major surgeries, and some artery side effects like bladder leaks causing collection and all these things. Cross-match testing is also very important. It's repeated just before the transplant surgery, and the blood from the donor recipient are mixed. If the recipient cells attack and kill the donor cells, now the cross match is considered positive. This means it has antibodies against the donor cells. This is different from HLA. This is different from the blood group antigen. So that's where 3 types of match must be done. Rejection, obviously, this is the body's normal response to fight a foreign antigen. The 3 types of rejection: one is hyperacute. This occurs within minutes, within hours of transplant, and the type is rare and is untreatable. Acute rejection is the most common form of rejection that we have always to understand in the post-op setting. Whenever you do a round in the post-op setting, you have to check the vitals, you have to check the patient's consciousness level, the output, urine output, and also you have to check whether the patient is having fever or not. Also, you have to palpate the recipient kidney. Okay, the grafted kidney, whether there is a tenderness or not, whether it's swelling or not. Okay, and in skin color changes or not. It's a very important finding you have to do in the normal rounds in a post-op setting. So it can occur after kidney transplant, acute rejection, serum creatine level, as you have to check the blood biochemistry also. Acute usually treated with a higher dose or different type of immunosuppressive medicine until the creatine comes to baseline. Chronic rejection, many years later, many months later, no known treatment. Okay, so these are the drugs used in kidney transplant, and this is basically, so in another day, another class, we will talk about the immunosuppressive treatment. You can get short notes on calcineurin inhibitors, but this will be too much for today's basic class, basic course on kidney transplant. So hope you understood the basic concepts, and if you have any question, you can always mail me, and you can always comment in the comment section, and you can share this video with your friends alike, and I will most help. It will most helpful for most of us to have a very short, quick going through of this video lectures before your exams. This will help you. Okay. Till then, bye bye. I will be coming again with another class.